Okay, well, I think in the interest of time, we'll get started. You're very welcome, everybody. Delighted to have so many joining us today. So my name's Jane Woodside. I'm Professor of Human Nutrition at Queen's, but I also chair the UK Society, or I'm a co-chair of the UK Society for Behavioural Medicine's special interest group in children's lifestyle behaviours, wellbeing and health. And that's, I suppose, designed for those within the UK SBM, although this is an open meeting and freely available to all, bring those together who are interested in the application of behavioural medicine to modify children's lifestyle and ultimately health behaviours. So we've had a variety of sessions as the SIG, either in person at the UK SBM meetings or more recently online. But we internally to Queen's heard a session by our speaker today, which was talking about sort of maximising impact of your research, which we thought would be particularly relevant and interesting for the members of the SIG. So we invited Mike along today. So I'm delighted to welcome Professor Mike Clarke. Mike is Director of the Northern Ireland Methodology Hub and also the Northern Ireland Clinical Trials Unit. And Mike has a wealth of experience, more than 30 years working in rigorous evaluations of health and social care, including randomized trials and systematic reviews. But here he's going to focus on what things to consider when you're designing and conducting research to ensure that it has an impact. It doesn't sit on a dusty academic shelf somewhere or embedded in a journal, and that the findings therefore can be used in practice. So Mike, thanks very much for giving up the time to talk to us today, and we look forward to your presentation. I'll just say, sorry, just before you get started, that please use the chat for any questions, and given, depending on the time that we have, I will address any questions to you at the end.
Great. Thanks very much, Jane, and thanks very much for the opportunity to repurpose a talk that I gave in another context, bringing into it some examples that will hopefully be of particular relevance to everybody who's watching. So as Jane said, I've been working for quite some time now in evaluations of health and social care. I'm not a practitioner of any description. I'm not a statistician. I'm basically someone who tries to help ensure that researchers do a good job, answer the right questions, and get the answers from their research into the brains of the people who might need to use them. I am an academic researcher, but I don't see myself as an academic who's trying to chase journal articles. I see myself as someone who's trying to help ensure that the research that people do is as useful as possible and is as used as possible. So I want to step back first, and the clicker will work. There we go. Step back. Why do we do research? Why do we actually bother with research? It's not about boosting our CVs. It's not about keeping ourselves in work. It's because we want to identify and resolve uncertainties, and they need to be important uncertainties. We are trying to answer questions that people really need to see answered. So why do we need good and useful research? Again, just step back and think about it. In a health, social care, educational context, it's because we want to improve the delivery of health or social care or educational issues or any other area, and we want to improve the outcomes. So how do we do good and useful research? And that's what I'm going to try and spend the next sort of 30, 35 minutes talking to you about, using some examples. And I would say there are 5 things to think about. There's clearly more than 5 things, but the 5 things for this next half hour or so: choose the right question, make the best use of what has gone before, and also start thinking about how can I ensure that my research contributes to other people making best use of it. Choose an appropriate study design, keep things simple, and collaborate. And I think if you can think about these 5 steps, and I'll illustrate each of the steps, you can start to see how you could maximize the usefulness and the use of your research. So choose the right question. I'm going to take you to an example from primary care. And it's 20 years ago, published in the Medical Journal of Australia. And it's a sort of fallback option if you get into a state of desperation when you're doing a piece of research and it all goes wrong. Can you still get an article out of it? So that's one aspect, but that's not what this example is about. This example is about how they made mistakes when they decided on the research question. They didn't choose the right research question. So the topic they were working on is patients with mild to moderate depression in primary care. And they decided to do a randomized trial comparing structured problem solving. So that could be things like crosswords, Sudoku, and that sort of thing, against drugs, standard drugs for mild to moderate depression, the so-called SSRIs. They set out to recruit more than 100 patients. They identified 114 potentially eligible patients before they gave up. Because instead of recruiting 100 or more patients, again, if we were in the lecture hall now, I'd be looking to the audience and I'd be asking you to shout out numbers. I'm not going to ask you to unmute, but just to think of a number in your head now about how many they actually recruited. So it's an important question. Mild, moderate depression in primary care. Many people present to primary care with it. Testing two different approaches. Problem solving, drugs. How many did they recruit? No one. They recruited no one after working with 114 patients to decide if they might be eligible. So let's just see what went wrong. First of all, they were looking for mild or moderate depression. So some of the people who presented were too depressed. What you'll see is if you try and add these numbers up as I'm talking, they will not add up to 100%. They will not add up to the 114 because some patients had more than one reason why they were not recruited. So about 1 in 9 that they spoke to about the study or they considered for the study were too depressed. A quarter weren't depressed enough. So they were potential candidates for a study, but they were not depressed enough to meet the inclusion criteria. Then we've got a series of very extreme things that we would desperately want to keep out of any trial, so that people with a previous episode of psychiatric illness, suicidal intent, drug or alcohol abuse, we probably would accept those as not eligible. Our question is still okay, but we would not want to recruit these to this particular trial. So we accept that fact. We know that the question won't fit everybody. But then a third of the patients that they identified were already on a drug treatment for depression. If they joined the trial, they would have to have stopped that drug if they'd been allocated to the structured problem solving. And then another third were receiving psychological treatment already, which is along the same lines as the structured problem solving. So they're going in with this question, trying to compare two different approaches to help people with mild or moderate depression. But 2/3 of the people who are presenting as possible candidates for the trial are already going down one or other pathway and don't want to switch. Some drug-related problems related to the SSRI. And then you've got, maybe the GP who would have been recruiting them. So 20 of the 114, the GP isn't sure, isn't confident about using problem solving. It's not that they're uncertain. If they're uncertain, they should randomize. They're just not comfortable with the whole idea of doing it. Another bunch ineligible. And if if we were in a position, if these were mutually exclusive, we could add them all up now. But I can tell you, all of those added up come to 107 of the patients. So again, there's double counting. So they were left with 7. And what happened? Those 7 patients refused randomization. So whether or not the GP thought it was the right question, no, they didn't. Whether or not the patients were the right sort for the trial, no, they weren't. So many of them missed the eligibility criteria. And then whether or not patients wanted to join the trial, the 7 remaining patients at the end of all of this application of the eligibility criteria, they themselves said, no, I don't want to join. So it's quite sad for the researchers invested almost certainly funding for the trial, invested time in the trial, but it wasn't the right question. I'm not here to say what would have been the right question, but the first step, if you want your research to have an impact, is to be able to do the research. And the step before that is to have a question that people will want to take part in that research. So let's move on, make best use of what has gone before. And as Jane said in the introduction, one of the things I've worked on for a long time are systematic reviews. In systematic reviews, we bring together the evidence from research that other people have done in order to try and get to a position where we can resolve those important uncertainties. And show you an example of the sort of thing that you can achieve. And sometimes you can achieve a really definitive answer with the systematic review. Sometimes you can achieve an answer that shows the need for more research. And so this example is to sort of counterpoise a few things. One is the value of the review to definitively bring together the evidence. And the other is the challenge that too many studies have not been designed well enough, have not got the right question, have not recruited enough patients or participants to allow them to really answer the question. Again, that research that leaves the gaps is not going to be useful or used. The systematic review may be useful and used in order to show people that we need to fill the gap. So here's an example from Luke Wolfenden and colleagues. It's a Cochrane review from a couple of years ago, looking at ways to enhance the implementation of school-based policies and practices to try and target the risk factors for chronic diseases. So can we do things with the children that will reduce the risk that they, as they grow into adulthood, may start developing some of the chronic diseases, diabetes and so on. So there's the Cochrane review. And again, just to get a feel for doing systematic reviews, they checked 19,000 records by looking in a variety of databases, PubMed, Embase, databases that many of you will be familiar with. They looked in trials registries for ongoing or closed but not reported studies. They checked through reference lists and they contacted experts. And they had 19,000 things to check through. Of those 19,000, they needed to look at 385 full text articles to see were these studies eligible. And then they were left with 27 studies that were eligible, coming from 81 articles. So many of these studies had been published more than once. And those 27 studies were 8 individually randomized trials, 11 cluster trials, and 8 non-randomized studies. So a vast amount of work, but saving the reader of the review from having to do all of that. They've checked 19,000 records. They've looked at nearly 400 full text articles. They're down to 80 articles, giving them 27 studies. And they're describing in great detail in that Cochrane review the study. So here's just some screen grabs of one of the studies, a study by Perry, telling us about the methods used in the review, telling us about, in the trial, telling us about the participants in that cluster randomized trial, telling us about the interventions that were tested in that randomized trial, what outcomes were measured in that trial. You can see that wealth of detail so that people could come and look at the review and see what is contributing to the review, and then assessing the risk of bias in all of the 27 studies in the review, looking at the risk of bias, looking at how likely or not it is that the individual study's result is a good guide to the truth. So you've got vast amounts of detail, which the reader is going to be very grateful for, in the sense that they know what is in this review. Whether or not we know that the vast majority of readers will not go into these tables and look. But this is a reassurance to every reader, every user of this review, of the level of hard work and diligence and thoroughness that's gone into the systematic review. And again, as I said, sometimes reviews have value, not because they give us clarity on what we should do next, on what policies we should implement and how we should do so in this context, but they show us the gaps. So after all of that work, they concluded very low quality evidence. It's uncertain whether or not the strategies tested improve the implementation of these school-based policies or practices. It's uncertain if they would improve implementation, if those that might improve implementation are cost effective, or if they have unintended adverse consequences. Again, highlighting the gaps, further research, but being very specific about the further research. So this review gives us a few answers, but really lays the groundwork for research into the future that could nail it. And the challenge being, reflect back on those 27 included studies covered in 80 or more articles. How useful were they? They just didn't tap into some of the key things that decision makers really would need in order to identify effective, cost-effective, and likely to do more good than harm ways of implementing these strategies to improve the future for these children in these schools. Next step, guidelines. So we want our studies to be used. Can we get them into guidelines? And again, what I'm urging here is when you're thinking about doing a study, don't think about all I need to do is get it into a journal. You need to think about, will people who are preparing reviews, will people who are preparing guidelines, will people who are preparing policy documents, even to a higher level, will people that are issuing new regulation or new legislation be aware of my research? How can I ensure that that happens? And again, for some of you, you will have opportunities in the future to get involved in the production of guidelines. Key outputs, key ways to get impact. So this is an example from the States, and it's looking at ways to promote healthy eating and physical activity, delivering things to in schools. How could you achieve that? And so what did they do? Well, they did a series of systematic reviews. It's not cherry picking. It's not saying, well, we have this idea in our mind that we would like to recommend. The document is detailed about how they did the gathering of the information. Going to maximize the trust that might be placed in the guidelines above and beyond the trust that you might place in the guideline because of where it's come from. Increasingly, we should be questioning, where are these recommendations from? How strong are these recommendations? Well, here is a guideline that is very strong and very clear about its methods. So it did a series of systematic reviews. It did reviews that look at the outcomes, long-term and intermediate. So very epidemiological reviews. This is that's not an intervention question. It looked at the eating behaviors of the children and adolescents, and then factors that might influence those behaviors, and factors that might influence their physical activity. So it was laying the foundation for possible recommendations about things you could do. And again, really crucial, strong foundations. If you want people to act on your research, your reviews, your guidelines, your recommendations, give them really strong foundations. Another large project, more than 6,000 records screened from a variety of literature databases. Again, some of you are going to recognize those names. And they look for two types of scientific report. Again, reviews are not just about randomized trials. Most of the reviews I work on are reviews of randomized trials, but that's because most of the reviews I work on are about the effects of interventions. Sometimes we need to look for other types of evidence from other types of study. Whatever our research is, we need it to be useful to answer the question that the user wants to see answered. We need to ensure that the user gets access to our research. So they looked at the randomized trials of interventions, and they looked at expert statements. They looked at other things, other documents, which we'll often regard as lower levels of evidence when we're trying to work out the effects of interventions. But they're looking at these statements to see what is being recommended. What is out there? What is being suggested about youth nutrition, physical activity, prevention of obesity? And 1,300 articles retrieved, reviewed, and rated for use in the guidelines. And I'm not going to read out, these were the 9 major areas of recommendation in the guideline. I'm not going to read through them, but you can see, as you can read them on the screen, they're covering a variety of things. They're making recommendations about what could be done at a very high level in terms of coordinated activities, what could be done with the children and their families, what could be done at the level of the school. How could things be delivered? Again, if these guidelines were followed, it would make a difference on the basis that these guidelines are built on a very strong foundation. The researchers who did this work that fed these guidelines created a strong foundation. And if I just skip you to the reference, these pages, it just rolls the references. 680 references, so 1,300 things were considered for the guidelines. It's an incredibly well-referenced document. And again, it gives you that strength of feeling that this is robust, this is strong foundation for any decision making. And it's using this as an illustration that it's not just about the study design that I work in most, randomized trials. There's a variety of types of research. There's a variety of types of evidence. You've got to make sure that you position your research and your evidence in the correct place. And you've got to make sure that you make best use of what has gone before. Lay the foundations. If you're doing a new study, we'd still like the foundations for that study to be based on reviews of what has gone before, not a new study just plucked out of nowhere, but a new study that has the right research question because it is built on what is already what is already out there. Choose the appropriate study design. So this is to take you to, as I've mentioned, the area that I work a great deal in, partly as the director of the Northern Ireland Clinical Trials Unit, where we're working closely with investigators across a range of disciplines, predominantly on randomized trials. Got to think, why do we do them? We're all consumers, providers, or payers for health and social care. So, as I said, I'm not a practitioner, but I go to my GP. I will use the healthcare that my GP might offer to me. I go to the chemist. I will be trying to decide what indigestion tablets to buy, what toothpaste to buy, what analgesics to buy. Some of you will be providers of healthcare. And we're payers, through our taxes. If we're on an insurance scheme or we're paying for it directly, we're all involved in this. We're all part of this process of delivering and receiving health and social care. So we hope that what we take, what we're given, or what we give will do more good than harm. But that requires reliable, robust, trustworthy information from the past to help us make good choices about the present and the future. And this is key when we start thinking about randomized trials, because randomized trials are a way that will help us to predict what is likely to happen if I use or if I don't use the intervention that was tested in the trial in the future. I would now argue that randomized trials are not really about what happened in the trial. It's about taking what happened in the trial and saying, is that what is likely to happen to me, or to my patients, or to my family, or to my population? It's about predicting the future. It's about having groups that follow different pathways of intervention, and then saying, in the study, in the trial, this is what they found. Is that what I predict I will find if I implement that into the future? Well, the idea is not new. So there's a project called the James Lind Library, and I would encourage you to Google it. Some of you will be familiar with James Lind as a naval surgeon in the 18th century who tested various things for scurvy and showed that fresh fruit was a good treatment, a good prevention strategy for scurvy. And the James Lind Library is an online collection of historical material about evaluations in healthcare. And strongly recommend just Google James Lind Library, go to it, and you'll find all sorts of rich material and fascinating material about the history of things. So here is some history. 17th century, 1662, Jan van Helmont talking to people about how to manage fevers. And he offered a wager, he offered a bet It's not clear whether or not this study ever took place, but he said, let us take out of the hospitals, out of the camps and from elsewhere, 200 or 500 people with fevers, pleurisy, etc. Let's divide them in half by casting lots. Let's then treat them. I'm going to treat them my way. And that my way, Van Helmont is saying, is not using bloodletting. You can do it that way if you want. And then let's see how many people, how many survivors we have. We don't know if the trial was ever done. If the trial was done, it would have been one of the first randomized trials. The idea isn't new, that we should use a technique such as randomization to allocate people to the different treatments. And people are going to, typically trial, we're going to allocate some to the treatment and some to receive usual care. It's perfectly fair. If we are uncertain about whether or not the new treatment is likely to be more beneficial or more harmful than usual care, what better way than flipping a coin or drawing lots to decide who gets what? So it's a robust design, but there are tens of thousands of randomized trials and not all of them are going to make an impact. So we've got to use the appropriate study design. If the question is, what is the difference in the effects of treatment or usual care? The randomized trial is the appropriate study design, but it's got to be done robustly and reliably. So keep it simple. We can do them in very complicated ways, but some of our best answers are probably going to come when we just keep things simple. So here's another example, another school example. Grab a cup, fill it up. It's an intervention to promote making drinking water more convenient and to increase school students' consumption of water during lunch. Why? Well, we know that water consumption among children and adolescents is low, and many children are not adequately hydrated, which is going to have impact on their health and probably on their education. If we could increase the water consumption of those children, it would address several public health concerns, and schools are a key partner, a key way of doing that. Children are spending time in school, maybe we could do it at school. So what the researchers developed was a low-cost strategy to improve the convenience and appeal of drinking water. That was with things like posters near the drinking fountains, cup dispensers near the water fountains, and recyclable cups. So what did they do? It's a study done in Boston in the States. Randomized, 5 schools had the grab a cup, fill it up strategy. 5 schools remained as usual practice. Nearly 8,000 pupils in those 10 schools. What did they find? They kept it simple at the level of the intervention. They kept it simple at the level of measuring the outcomes. Main outcomes were simply how much water is consumed during the lunch break, and what proportion of the students at lunch have a sugar-sweetened beverage. And they simply measured both by having observers in the cafeteria, observing and recording. No complex involvement of the students, asking them loads of questions, no complex blood chemistries. Observers watching, counting, recording, and then analysing. And a very simple intervention. What did they find? The percentage of students in the intervention schools who were observed drinking water during lunch increased by 9.5%, more than doubled in comparison to the control group. And the percentage of students in those schools who were observed with a sugar and sweetened beverage fell by 3.3%. These are not massive effects, but these effects, when you multiply them up to hundreds of thousands, millions of school pupils, could make a substantial difference. Good trial, simple intervention, simple outcomes, important findings. And then collaborate, the last of my 5 key things. This is a trial from outside the areas that many of you, if not all of you, would ever work on, but it's a trial that I was involved in many years ago now in Oxford, and it's the trial I am proudest of being involved in. No doubt about it, and don't mind boasting about it. It's called the International Subarachnoid Aneurysm Trial, shortened to ISAT, and it looked at, I'll explain what the condition is and the treatments are in a moment, And the first, the groundbreaking paper for it was published in 2002 in the Lancet. There have been subsequent follow-up papers, and I'll mention those in a moment. But we were working on this through the 1990s. What is it? Well, a subarachnoid hemorrhage is a bleed on the surface of the brain where a blood vessel has a weak spot called an aneurysm on the surface of the blood vessel, and that bursts, and it's going to bleed. Now, it's tiny, it's millimeters. At a push, maybe it's 5 to 10 millimeters. You're not going to die from bleeding, but you don't want bleeding onto the surface of your brain. It's going to increase the pressure on the brain. It could damage brain, so we don't want it. What happens is, for some patients, the bleeding stops, it clots, just as if we cut our finger, we'd get a scab. So the aneurysm clots, but it's now at very high risk of bursting again. So we've got to do something to fix it. If we just leave it, the patient is at very high risk that it's equivalent of the scab will fail and they'll bleed again. And you'll have all of those nasty risks all over again. So the question is, what's the best way to stop the aneurysm from bleeding again? Leading to the ISAT trial. And the ISAT trial compared two different approaches, endovascular coiling and neurosurgical clipping. And an easy way to think about this is imagine that in the winter, a pipe under the building has a weak spot. The water freezes. Sorry, the weak spot bursts. As the water comes out, because the ground is so cold, the water freezes. The water in the pipe is flowing quickly, so it won't freeze. But the water that comes out of the burst freezes and clots and stops any more water coming out. But our worry is that when the summer comes along, the ground will warm up, the ice will melt, and the hole will appear again, and the water will come gushing out, and it won't stop. So there could be two ways we could conceptualize fixing that pipe. One way is to dig a hole, go down to the pipe and patch it, fix the weak spot. And that's neurosurgical clipping. This is not clipping the blood vessel. You can't clip the blood vessel. The blood vessel is feeding the brain. You're clipping the burst spot, clipping this bit of ruptured blood vessel. So that's what neurosurgeons do. Lift the skull, go in, get down there, put a clip onto the weak spot. Blood's still flowing here, but it can't flow out anymore because there's a clip on the place that burst. Endovascular coiling would be like sending a little robot into the water pipe. The robot gets to where the burst is and it fills the bulge where the burst was with something, and that's a coil. That's an endovascular coil. So you go inside the patient's blood vessels and up to where the burst is. So very different procedure. Very different people involved in this. The neurosurgeons are doing the clipping, and what we call the neuroradiologists, who are the people that would do things like MRI scans and angiograms. They're ones that, if we simplify it, they're the ones that take the picture of the burst to show the surgeon where to dig. They were the ones who were doing the coiling. More than 2,000 patients were recruited. We could theoretically have said, let's find a bunch of patients who are coiled, let's find a bunch of patients who are clipped, and let's compare their outcomes. But the differences between those patients could well be driving the results. We didn't go looking for 2,000 patients. They were randomized. So patients presented with a subarachnoid hemorrhage, they were spoken to, or their family members were spoken to by the surgical team. They were told of these two different options, and if they agreed to be randomized, the equivalent of flipping a coin sent them down one or other pathway. They were randomized. So we've got 2,000 participants. And this study, one of the reasons I'm so proud of it, is it just blew away all of the other evidence. There's a few other trials out there, but they're of the order of a couple of dozen patients or maybe 100 patients. Here was 2,000 patients. So it's the right question. It needed collaboration across dozens of hospitals in many countries to get the 2,000 patients, and it took a while. It began in 1994 with a pilot, which was quite slow burning. 1997 went to main trial, bringing in more centres, bringing in more collaborators. And I remember these days back at, and now I'm looking back at the beginning of the century, 20 years. The Data Monitoring Committee were overseeing the data in confidence. They recommended on the 29th of April 2002 that the trial closes. The trial was closed on the 2nd of May, and the first report was published within months. And it concluded that coiling was better than clipping. Clipping had been around for 30 years. Clipping is done by neurosurgeons. I doubt there are any neurosurgeons watching me now, but you can all imagine how confident neurosurgeons are about the quality of their work, the quality of their intervention. They lost out to the neuroradiologists. They lost out to the people that are accustomed to taking the pictures of the brain for the neurosurgeons to go and fix. And it was gutsy. This trial was led by Andy Molyneux in Oxford, who was a neuroradiologist, and Richard Kerr in Oxford, who was a neurosurgeon. And they agreed to put their disciplines head to head. And the participants, the participating professionals, they agreed to go head to head. And it published in the Lancet 2002, follow-up paper in 2005, bringing the follow-up forward. Again, just to show you that the picture on death, do these people, like, this is a very serious condition. The old way that we would talk about it is a third of people that have this bleed will not get to hospital. Sadly, they're going to die before they get to hospital. A third of the people then will have long-term problems, maybe disability from the bleed, or will die from the bleed in the coming weeks and months. And then a third might recover. These are the graphs for ISAT, taking us out to 6 years of follow-up. And you can see early on, 5% within the first few days or weeks of the procedure, 5% of the patients sadly died in both groups. But then as the follow-up went on and on and on, over the weeks and months and years, we see clear separation. We see that the difference is of the order of 5% between the two groups with the longer term follow-up. You might think, well, what's 5%? Well, 5% is 5 fewer dead people per 100 treated with a coil instead of a clip. Matters. When we looked at the ISAT data on its primary outcome, which was, does the person survive to 1 year and not without being dependent on the care of others? In the neurosurgery group, it was 31%, so about a third were dead or dependent at 1 year, but it dropped to a quarter in the endovascular group. Okay, and we can rely on this. This is a randomized comparison. The only other explanation for this is chance, and we rule out chance by doing our statistical tests and says this is so unlikely to be due to chance, it's got to be down to the interventions. So what was the impact of it? Since ISAT, many people have had a look back at data and they've looked at, well, were people using coils? Were they putting coils in or were they clipping? And you can see some data there. There's a variety of studies done. In the UK in the early 2000s, coils were beginning to get a bit more common. 2003, though, on that slide, is after ISAT reported. So in one, there was about a third, in two, 38%, doubles after ISAT comes out. You got USA data there. USA was way down on coiling before ISAT. Then the later data. By 2011 in the UK, 86% of people with a subarachnoid hemorrhage were being coiled. In India, it was 95%. And in the US, by the early 2010s, it got up to 55%. We have no other strong argument for why this changed other than the results of the ISAT trial. It was collaborative. It was relatively simple in terms of follow-up. It's a difficult procedure, but it's what has to happen with this condition. It had the right question. It said, what's the best way to stop this from bleeding again? Difference has it made? Again, now just wrapping everything together, the American guidelines. So even though the Americans were slow to adopt and had been very slow to adopt as coils were becoming available, recommends it. Says if you could, so this is 2012, 10 years after the ISAT result. If you can do both then do the coiling. In the UK, the NICE guidelines are currently out for discussion, and so this is, bang up to date almost, in the sense of what are they saying now. They were saying this earlier, but just to show you, what are they saying now? If interventional treatment to secure the aneurysm, that means to stop it from bleeding again, is an option, then first choice is coiling. If you can't do coiling, then go to clipping. Making a difference. Not only is it the guidance, it's the practice. And again, reason for being so proud of it is we can look back and we can say what made a difference. What made a difference was a large, simple, randomized trial of more than 2,000 willing participants, willing surgeons, willing neuroradiologists, because it was the right question, because it was collaborative, because it used the correct study design, and it built on the evidence that was already there. So just to finish, just to put up this slide again, you've got to think about, have I got the right question? Am I using what has gone before? Have I got the right study design? Can I keep it simple? The simpler you can keep it, the bigger the study can be. The bigger the study can be, the more oomph I will tell you that you'll have, and the more possibility you will have for having impact. And collaborate. Collaborate will get you more participants, more colleagues. It will also increase the uptake, because we know that people that take part in research are more likely to follow the results of the research and to use the results of that research in practice. But it's also going to be the case that if I see this is a study that was done across many centers in many countries, many different schools were involved, many different teachers were involved, I'm going to feel that's going to apply to me. If it's one school with 5 teachers, I'm not sure it's going to apply to me hundreds of kilometers or many years away. So I'll finish there. Thanks very much. As Jane said, welcome to take comments or questions now. I hope it's given you a flavor for how, research is not about journal articles. Research is about right question, having an impact, changing practice. Thank you.
Thank you, Mike. It's really valuable, I think, particularly for our ECRs, where we are just thinking of, CV development, get that paper out, but we've got to make it relevant from the start, and just seeing it in the sort of simple bullets is really helpful, and obviously hearing the examples from your own work where there has been such a great impact. So thank you so much. I'm going to ask people to put questions in the chat. I have one or two, and there's one also has come through already, but ask others to put in. When we think about randomized trials, my sort of grief is always, if it's a nice drug or even a nice vitamin supplement in my own world, that's lovely in terms of control. But in behavioral medicine, dietary interventions with the food or whatever, it just gets a little more challenging. So that simplicity of design, it just gets difficult. So do you have any thoughts or words of advice, I think, particularly on consideration of control?
Yes, there's a few. So on the simplicity, one of the reasons for finishing with the ISAT trial is clearly the interventions are incredibly complex interventions, highly skilled interventions. They're not the complexity of something that you might be doing around nutrition and lifestyle advice, where there's lots of things going on, but they are still very complex. But so first thing is, for simplicity, maybe look at the outcomes you're going to measure. Can I measure them reliably? From the control perspective, where you're going to have the challenges of what's actually going on in the control group, can I understand what are the control schools doing? What are the control pupils doing? What are the control people like me doing when my GP gives me some advice? I would say that you try and find simple ways to measure it. Because one of the other things I'll often say to people when we're thinking about trials is, when you've finished your trial, there'll be people that do not like the result. So they will look at ways to dismiss your result. They will look at your methods. They will say things like, yes, but maybe the answer is this. Maybe the cause of the answer is this. So I'd encourage all researchers, this would apply for the usual care, the control conditions. Ask yourself as the researcher many times, why am I wrong? Why is my answer wrong? When you've exhausted all of the possible reasons that it's wrong. For example, there's not a big bang of the intervention. Well, maybe the intervention doesn't work, but maybe the control's caught up. Ask yourself all of those things. When you've exhausted all of those alternative questions, then you might be right. But I would push, ask yourself those things. Ask yourself those things at the design. You know, how can we ensure that the control group stays as a good control group? How can we assess whether or not it was a good control group, so that you don't have the person at the end saying, yes, but I think the reason you got that result is this, and I'm putting your research in the dustbin. Try and put your own research in the dustbin before anybody else does, and then build it so that it cannot fit in the dustbin. It cannot go in the dustbin.
Great, thank you. I might need to take some notes here. So I'm seeing lots of thanks in the chat, Mike, and then a couple of questions. Do you have any tips or thoughts about research impacting policy and decision makers, as the timelines don't usually align? How do we ensure the research question remains relevant for impact?
Massive challenge. I mean, we other people that have done stuff have said, you know, it can be 10, 20 years between the beginning of the research and its possible uptake. And the counter argument is that the policymaker wants something for tomorrow. I think a few things. One, involve the policymakers. Choose if we go through the 5 things almost, choose the right question. What is the question that the policymaker wants to see answered? If they want it answered faster than you can deliver it, you're not for them. But many of those policy questions aren't going to be over in a week or 2 weeks or 6 months or a year's time. They're still going to be around, you know, in however many years it might take to do the research. So I would say you've got to work with the policymakers to ensure that the question you're trying to answer is the one that they really want answered. Think about the timescale for delivering their answer. But I would, you know, very often we've put, and this must be true of you as well, Jane, policymakers come to you and say, I need an answer by tomorrow. And you bust a gut and you give them an answer by next month. And they don't do anything with it for who knows how long. And you're thinking, I could have took my time and delivered something really robust to you in time for you to actually start acting on it. Yeah. Because I think, you know, sometimes it's the policymaker, if you can't give them it by tomorrow, then they still might want it in a few years from now. But I would go, I'd almost look at my 5 things and say the key thing is choose the right question. And that means engagement with the policymakers. Academics should not be sitting in the universities thinking they know what questions need answering. They've got to work with the people that are going to use that research, because those people won't use your research if you've answered the wrong question, no matter how good your answer is.
Just add another question around, you know, when you talk about the guideline developments and the systematic reviews in which those were based, which is fantastic, but you know, that still implies they do the research, get it published, and then hope that there's a, you know, so are there other ways? I mean, you know, writing a policy brief, you know, for ECRs, about other ways they can get that awareness of the work across to the right people.
So yeah, policy briefs, figure out who your audience is. Your audience is not necessarily going to be looking for journal articles. Your audience is not necessarily going to be going to PubMed to find your study. So figure out who the audience is and figure out the routes of the conduits to get your stuff to that audience. And that's both the actual sort of pathway you would follow to deliver it to them, and then what you're actually going to deliver to them. They do not want to read. So we take the Cochrane Review examples, so, you know, hundreds of pages, dozens of pages of characteristics of the included studies, lots of hard work by the reviewers. The policymaker probably simply wants, when did you do it? What are your conclusions? What should I do about it? And we've got to think about, we've got to improve that side of research activity as well, what people talk about as KT, knowledge transfer, knowledge translation. How do we ensure that we don't overwhelm the policymaker with all of the stuff that might fascinate the methodology people, such as myself? They want to know, what did you do? When did you do it? What did you find? What should I do? So we've got to find ways to get that message to them, and we've got to find the pathways to actually be walking along to then hand over that message.
There are two more questions, but I'm going to reverse the order in which they've come in, just because I think there's a nice finish here. So one is, in terms of the 5 bullets, have you derived those from your personal experience and reflection, and you know, your experience of studies that didn't get attention and make a difference, Or is it more sort of evidence-based than that? Does it map onto frameworks to best promote take-up of evidence? So keep it simple. So our question asker says it really rings true, but is there an evidence base for that?
No, probably not. So I'm not one for theories and logic models and frameworks or anything. It's experience. So I think some of them, there is evidence on Collaborate, there is evidence that shows that people that participate in research are more likely to uptake and use the findings. So there is evidence of that. People have done those sorts of studies. Some of the other things are gut feeling. So again, if we keep it simple, one of the trials that has made most difference for COVID-19, and some of people will have heard of it, is the recovery trial. And the recovery trial was built on principles that came out of the 1980s for some very large trials of the treatment of heart attack. We said simple interventions, cheap interventions, easy to deliver, don't measure very many outcomes, get thousands of people, and then your average is going to be really robust. We know, so again, those simple trials from the 1980s influenced the team that worked on the recovery trial, and the recovery trial we know is having a substantial impact, and definitely that the recovery trial team for COVID-19 would say one of our fundamental principles was keeping it simple. So some of it is gut feeling, some of it is anecdotal example, the sort of lowest level of evidence on many people's pyramid of evidence. But I've not seen anybody argue that a complex, small study is the way to go. So I'd love, if we base on anecdote, then if I see those anecdotes, then I would reflect on them. And again, but the point is those 5 are really, they are personal reflections, things that if I sat down and said, what really makes a difference? And it's that they follow the journey. The 6th has got to be get the message across.
Yeah.
If someone said add another one, you've got more time, you've got another 10 minutes, then I would add get the message clear. The question you may raise, Jane, about policy briefs and so on, knowledge transfer.
Okay. Great. So somebody here really appreciating the pragmatic approach. Great talk, really useful practical tips to implement in practice. But the last question that's come in, Mike, and it's a good one to finish on, is you talked about the trial and the aneurysm trial, but maybe the answer is it. But what piece of research have you been involved in that you're most proud of in terms of impact? And I suppose in my mind, I wondered whether you wanted to mention evidence aid as well.
Okay.
Just another thing that you've been involved in. So over to you.
Okay, so there's a few. So ISAT is the single trial. The big systematic review I work on and have worked on throughout my career is of trials of the treatment of women with breast cancer. It's a monster project. I've been involved in it since I began research. It itself is approaching its 40th anniversary, and it's the definitive bringing together of all of the trialists involved in the treatment of women with breast cancer, pooling their evidence in a whole series of systematic reviews and meta-analyses. So that's another big hitter, which just, everybody working in breast cancer research, people working on guidelines in breast cancer would turn to. And then evidence aid, which you kind of mentioned, Jane, that's an attempt to get the evidence from systematic reviews to people working in disaster and humanitarian settings and say, look, this is the evidence that might help inform you in a better response to an earthquake, a tsunami, a windstorm, flooding, and over the last 2 years, COVID-19. It highlights the sad reality that in areas such as disaster and humanitarian sector, opportunities for research are not taken. And some of the discussions I have into that sector, I bet are the discussions that the medics were having in the early 1980s. About the need for a robust evidence base. And people will say, oh, you can't do it. Well, people said you couldn't do the ISAT trial. People said you couldn't do the big heart attack trials. People said you couldn't do the recovery trial. These things can be done. And that's where we hope to see things moving in evidence aid context, is to encourage people to do research that's ethical. And I would strongly argue that if you don't know the best way to do something, the most ethical thing to do is to actually study it, not just to shut your eyes and do one thing. And so that's where we would love to see things moving, is where people are affected by disasters, conflict, forced migration, actually have the right to evidence-informed interventions.
Great. Well, listen, We're literally almost out of time, so thank you so much, really, for taking the time. I think that it's been so valuable to hear your reflections on how we need to be thinking as we try and drive impact. And I think for our audience, which is largely ECR, that's been really useful, and great positivity coming through in the chat. I'll just finish by saying to anybody, this is an open session. It has been recorded. It will be available on the Genius, which is the UK School Food Network website, and will also hopefully be available in time on UK SBM website. If you're interested in joining UK Society for Behavioural Medicine, then there was a link up at the start, and I think it's just uksbm.org, or just Google it. But certainly there's lots of opportunity for further work, collaboration, discussion events via that society. So very much encourage you to have a look at that. Mike, thank you so much. I really appreciate your time, and I hope everybody enjoyed the session. Thank you.
Thank you. Thanks.